So let me just start with one question while the audience is thinking about it. You mentioned this a little bit, Peter, but I wondered, Nancy, if you could explain how you think about informational risk and privacy in the continuum of risk that you outlined.
Yeah, great, thanks. So informational risk is really important, and a lot of people are thinking about it. What I do think is really critical is to not separate our thinking in terms of what kinds of protections we want for research from what kinds of protections we want for clinical care, particularly with electronic records. There's lots of studies that show the numbers of people who touch every clinical record, and it's a really large number. So it seems that it is very important to think about how to protect patients' private information. And part of it has to do with sort of technical solutions, and part of it are these, query things and making data anonymized and then putting it back with identifiers, and part of it just has to do with firewalls so that the wrong people don't get access. But I guess the key points I want to make is, of course, privacy is really, really, really important. The second point is we have often said in research, but the privacy concerns, and those are really just as important in the clinical context. I don't think it adds a new question.
Hal left. This is wonderful, and Nancy, and I really love the way that you are reconceptualizing the notion of risk and need for IRB approval, et cetera. I think it makes perfect sense. And I think the commentators added examples of how our current process, as implemented by many IRBs, is probably actually unethical. We're keeping good care from more people. I'm taken back to Brent James's comment about how maybe only 20% or less of the important findings that they're coming up with actually end up getting published. And so what I'm wondering is comments from the group on using incentives. I'm an economist, not an ethicist, whereby a small percent of, let's say, Medicare and Medicaid and exchange dollars might be made available to those organizations that do QI under appropriate guidelines and as expanded, and move it into the public domain. So you only get those dollars if you establish a process so that Brent can actually go to his CFO and saying, there's some extra dollars coming in here because we are publishing. And then it gets out there. This doesn't have to be New England Journal articles. This has to be out there for the other QI people to look at and say, oh, they've done this, let's go do it. Thoughts on this?
I think it's a great idea, and I think that there are probably additional incentives that could be put in place both within systems and publicly for both dissemination, but also for the implementation phase. And it's not to, obviously, a lot of smart people here in the room. I mean, it's not to suggest that every project when it's done is ready for widespread implementation, but there are some number that are. So, yeah, it's a great idea.
I just want to give a shout out to Aaron Holvey and the EDM Forum and EGEM's publication, which is enabling many of us who do these kinds of quality improvement types of projects to publish in the practical aspects of how we get the work done. So that's a real good resource that's become available.
I'll just add that we're going to help Brent publish, because in the High Value Collaborative, to sign up for that, you have to agree to transparency and you have to agree to publish. So you'll start to see some articles coming out with institutions identified, with the actual variation in cost, outcomes, et cetera, including Intermountain. And remember that Intermountain or Mayo in Salt Lake may be very different than in their other states, Rochester versus Florida versus Arizona. The results are quite different, and we're going to start uncovering some of that and help publish those things. And the other thing is, if they're doing it really well, how are they doing it? Case study kind of publications that don't get the kind of press in large journals. we're going to publish all the case studies of what actually was done to change it. So that's the hope.
Yeah, Steve Finn, VA. I just wanted to echo Hal's comment about Nancy's presentation. I always find it refreshing. You know, we've in some ways at VA adopted many of these principles in a handbook which governs our you know, leadership in terms of what we call operational evaluations. And one of the things I think that at least is worth considering that came back was from our ethicists, kind of, you know, sort of backed into this, saying many of those activities which were on your final categorization actually were somewhat indistinguishable from activities which administrators are already doing, and, you know, beg the question as to whether those things ought to be under some sort of, you know, evaluation. Needless to say, it created, you know, a lot of pushback about that, and I'm not advocating for that, but it was sort of, you know, it's the other side of the coin, where some of these activities now would be somewhat difficult to distinguish from things which corporate would say, these are what we do all the time, and now you're having rules about how they should be you know, governed. So it's just, I think, you know, as you think about it, because someone's going to look at that and say, no longer will it be different between QI and research. The question will be QI and routine operations, and what are the differences there, if there are any.
I want to share an anecdote, and I'm not going to get the quote right, but at the beginning of this project, one of the things we did was convene focus groups of sort of a lot of the kinds of people in this room, and actually there's a few people in this room who were part of our focus groups, and we asked a lot of questions about how does your institution distinguish, and what are the solutions you've put in place, and what are your challenges. And there was one person in one focus group who, with a little bit of a twinkle in his eye, but was being absolutely honest, said, well, the way we've solved it at our institution is that we've tried to create two separate offices. And in the quality office, we make sure that we use words like survey instead of questionnaire, because questionnaire sounds like research. And we call it project instead of study, because project, and there was this list of vocabulary, and he said, and that way we find ourselves, we don't get into difficulty.
Rich Burley from Nationwide Children's Hospital in Columbus, Ohio. If publication is one of the mechanisms that we disseminate improvement work, I was struck a little bit by Susan's comment, very special comments that you had, very erudite, but you said QI community needs to stop being afraid of randomization. I would say that the more traditional research community needs to be less afraid of statistical process control and interrupted time series with upper and lower control limits. I think that that's a statistically valid methodology to publish our work and show improvement. And so if we want to get those papers in New England Journal and JAMA and some of the high impact factor journals, I think editors from those journals need to be willing to look at statistical process control as a statistically valid way to show improvement over time, just as much as the traditional table with the p-value and all that sort of stuff. So I think if our goal is to publish and to disseminate this information, I think the broader research community and editors of journals need to be more willing to understand and look at those methodologies, because they're valid methodologies, just like the more traditional randomization methodologies that we're all used to as scientists. So just a little comment on that issue.
You know, I think there's, I think it's a failure of our education to say that the randomized control trial is everything. Having just sat on a federal guideline that only used randomized control trials, many of which were under 50 and an N of 50, you can run into a lot of trouble. I think that we need to operate better in the gray space for observational research, quasi-experimental, all of those things where you actually do have a really well-conducted study, often large enough, often across multiple health systems, that can really suggest that you are moving the field forward. And I do think that has been better in a large number of the journals who've published non-randomized studies that have made it to guideline and really affected what we do. I think the balance for quality improvement is when I don't think there's anything wrong with control charts and the statistical processes that we employ. I think it's sometimes the way in which we employ them and the period of time at which we expect something to change and whether or not there's certainty in those metrics. And that can change if we put many people together. But I think too often what we do for quality improvement is someone does an anecdotal report on a very short amount of time in a small number of units or in a single hospital or in a single clinic. And there isn't enough to be able to say that that has moved the field. So I think the publication part will teach people also, because some of them say, I don't want to publish because I don't know how. I don't know how to write a paper. So I think as we move forward, we learn because it gets out there. People tell us or tell them how to improve on the research and how we can do it in a pragmatic way.
I mean, I think the Squire guidelines outline how you can publish quality improvement work, which includes statistical process control. I mean, I understand both sides. I just wanted to make sure that the QI side of this got appropriate representation with respect to ways to show scientific validity of improvement of a process over time.
I wear both hats, so, but I will say that one of the best things that's happened to the field of infection prevention is to move into cluster randomization, and that there are things about randomization that are highly protective and that can give you definitive evidence much faster and with more certainty. And so not that it has to be the way every time, and there are many things that will never be done in a randomized fashion, but we have to be able to move randomization in because it in many ways gives us a lot of the security that we can't otherwise control for in our day-to-day measurements of what happens in a hospital.
I'll give you last word.
Yeah, Lucila Ona Machado from University of California, San Diego. I like the notion of no additional risk. What I sometimes have a problem with is how do you quantify risk, even baseline, right? So that you know there is an additional one on top of that. And I wonder if you encountered the potential issue that privacy is used as an excuse for not allowing research that is not of interest or timely for the interests of the organization.
Who would like to answer?
I guess.
Peter.
I think so far it's been honestly it's been a little bit difficult to unpack what's behind the concerns from health systems about the privacy concerns. Some of it is what we would all think of as our own desire to maintain our personal privacy, and physicians' desire to make sure that their patients' privacy is preserved. Some of it may have to do with things like competition or other sorts of motivations that don't have so much to do with research, but other kinds of motivation. And I think currently we don't have a good vocabulary for even describing what we mean or describing how much risk of loss of privacy exists. And I think making physicians and leaders more aware of the actual quantitative risk could be something that's helpful in the future. John?
I'd like to add more to the discussion about research. Renu Kaushal from Weill Cornell Medical College, and I'll turn this way because I can't seem to swing the mic around. I've directed a large consortium for the last 8 or 9 years that has evaluated health information technology across New York State. New York State's a real front runner in terms of investment in health information technology and has now invested almost $1 billion into HIT. And it's been a very interesting tension between what the policymakers want immediately to know in terms of the results of our studies and what we as academics would like to publish and the types of journal articles that we don't want to jeopardize. So I'm going to argue both sides of this conversation for a second, and I'd welcome responses. One thing is that we've really separated out the concepts of programmatic evaluation, which in my mind is akin to the type of QI evaluations that I do as well, from research. And what we've been increasingly learning is that we can translate fairly quickly rigorously designed studies that will lead into academic publications, but we can translate our findings into rapid headlines that work for policymakers. And then we can partner with the communities that we're evaluating to create generalizable lessons that they can start working on and chewing on right away without jeopardizing our publications. But that going through the process of the publications is so valuable because every once in a while you run into a statistical issue you didn't foresee or a methodological design issue that you didn't foresee. And so as we move forward with New York State and these ongoing discussions, one thing that we're really doing is separating out the concepts of evaluation from research. And we're finding that that's a helpful way to, a helpful paradigm to help people tease apart these two very important concepts.
I think people talked about this before, how actually planning the research is actually an important process, and whether it turns out in something you do as a quality improvement project or a publication, that thought process, what is the hypothesis? What is the question? What are the measures? How are we going to evaluate that? That process, whatever the end use of that is, seems to be, whoever mentioned that earlier, somebody over there, I think is really a powerful thing to think about. Even as young investigators we all work with, having them figure out what question they're trying to answer in a succinct way. The headlines, people can't remember the headlines from yesterday. You know, tell me what the headline was in the Wall Street Journal yesterday. I don't know if you know, but so memory is an interesting problem, but separate discussion. But I think that process that you're doing probably has tremendous impact on all the people you touch by that work, whether it actually gets published or not. And I think that's what Brent's argument is. There's so much to gain out of this rapid questioning and answering questions that's really important. And the publication, I think, for the society is important. If we can learn from that, because we're all thirsting to get better and try to find a shortcut because we can't afford to do everything. But that's my thought.
You know, I think we're making strides in that direction, and I think the discussions that NIH and PCORI can have with the major journals, it really reflects only a subset of papers that you really have to be very, very tightly controlled about, the ones that are the large trials that probably have the most information to give to the field, but those are the ones. And I do think that with the movement of open source to get the information out, that journals can and have turned around papers in a matter of days sometimes, or a week or so, when it is deemed to have great public health importance. And maybe what we need to do is start the conversation that that definition should be broadened from what it is, because right now it's really restricted to true public health, things that are public health emergencies. But I do think that in terms of major trials, that maybe we can advance the discussion to have the major journals consider a rapid review and a rapid release upon determination that it's been peer reviewed and is proofread and ready to go.
One thing, though, Susan mentioned earlier, I think is really important. You know, she was just reviewing trials with 50 patients in it. You know, that seems to me an ethical problem, because if you've designed something that you can't actually get an answer to, and you've exposed people to that issue. And there's no shortage of journals, by the way. The problem is what's being published. So these larger cohorts of populations where we actually can answer a question using the right methods becomes really important. So
Again, that's context dependent, obviously, so it's a longer discussion. Lorraine?
Thank you. I wanted to build on Peter's concept of value and also to raise the issue of accountability. And I'll give an example of what I do in my nonprofit, which is LymeDisease.org. When we do large-scale surveys with a patient population, we'll get 5,000 responses. We have a sort of social contract with them. So first is that we're going to ask questions that matter to them. And second is that we're going to do something with the data that is for the benefit of the patient community. And then the third piece that goes into it is there's actually an accountability equation, because at the end of the day, if we come back and we've misused data, like let's say we have sold it to pharmaceuticals to use to determine what patients they should target for X drugs or something like that. If we used it for a purpose that was other than the social good that they contemplated when they filled out the survey, then we'll be held accountable. And the way we're held accountable is they don't answer the next survey. And part of our obligation is also to publish, is so to make that information available publicly. So I just think that when we're thinking about how, part of what I think you're raising, Nancy, is we're going to be renegotiating a private-public societal arrangement for how we're going to be dealing with healthcare data and the public good. And I think these are factors that we need to be taking into account as we go through that process.
What we've mostly discussed this afternoon is changing regulatory oversight, starting with the principles up, and as Nancy so nicely put them out. And I think that makes a ton of sense. My question is at the other end. You can view each multi-site study, particularly among people that or entities that do multi-site studies together a lot, as a natural experiment. And those natural experiments could be subjected to various metrics. And so my question is, what is the role of empirically measuring things like time to IRB completion and so forth in the process of reform? A simple example from Kaiser is that with 7 research departments, 7 IRBs, simply looking at the natural history of these studies from the initiating IRB, time of review for subsequent IRBs, we learn a lot about the pain points, the barriers, and really a lot about potential solutions to improve the process. So I'd love to hear more of your thoughts about how we can use metrics to improve regulatory oversight.
Yeah, thank you very much. So independent of this context, independent of the learning healthcare or comparative effectiveness context, there has been work, and there's room for so much more, exactly on what you're saying. So there are some studies published that look at things like time to IRB approval and certainly what everyone has already said about variation in IRB approval and a little bit on the different kinds of studies that really trip up IRBs. I think this is sort of preaching to the choir in this room that metrics can be helpful for quality improvement, and IRBs are no exception. I won't go into the details, but I also can give anecdotes about the way that IRBs at Johns Hopkins have used metrics to change things and then implemented a couple procedures that I would call very low effort that made a big difference, and a few others that were very high effort and resource intensive, but that also made a huge difference. And it's critically important. So you're right, there's, like with all problems, there's multiple pieces of it that we need to be thinking about.
And
So can I just annotate that?
Sure.
So, and time to IRB approval or first enrollment or whatever it is one measure. We don't have very good measures of quality, which is something that you've heard here embedded. The other thing I'll say as an example of improvement is at all the Harvard-affiliated institutions, we designed a master reliance agreement about 6 or 7 years ago, which actually was the basis of Peter's and the children's group. It took 2 years to get the first 5 institutions, all quality institutions, all believing that they were the only ones who could do an IRB review with any certainty and elegance, to be able to rely on each other and innumerable hours of lawyer time. Then once we got the Harvard, these 6 groups together, then we sort of put out the master reliance agreement and said, you know, if these lawyers can live with it, either sign it or don't sign on. And now we've got all of the Harvards and then all of the Harvard affiliates, and now New England is growing it. We've done over 1,000 protocols in that time. And, you know, this is now the challenge from people who wanted to have a one by each conversation about whether this was a protocol that was appropriate for reliance or review. They now don't want to do that. They don't want to have the conversation anymore because they trust each other to do that. And this is all comers, not just QI or exempt and minimal risk, but full board review. So it's really changed the sort of culture amongst this, and we need to engender that kind of community further. And I think funding and sponsors can help that.
Well, and to connect the dots with one of our themes today, which is sustainability, I think it's easily apparent that networks that can demonstrate to funders and others that they can do IRB reviews rapidly and efficiently are going to be more desirable funding partners. So this is not an exercise in isolation from many of the other things we're discussing.
Ken? Last question.
The same problem Ray New had. All right. So, you know, if you're an automobile driver, you certainly hope and expect that General Motors is aggregating the data across all the ignition switch failures and detecting the problem early and fixing it. The public is shocked that that was not happening. Now, the public obviously should be equally shocked about the things that are not happening in the healthcare system. So I have a two-part question. The first part is, how do we bring the public around to that level of understanding and recognizing that there will be a privacy advocacy that I think misunderstands what many people in this room are trying to do. An important voice, but one that misunderstands what we're trying to do. And the second question is, given your experiences in networks, and you know, in here are 11 networks that are trying to get set up. And Barbara knows well that, for example, in the Boston-based skills network, we're trying a reliance agreement, as was just described. And in the pediatric network, we're part of that reliance agreement too. But so that's one thing. So the two-part question is, first of all, how do we get the public engaged? And the second part is, what, from your experience, besides the reliance agreement, are there other trust building or IRB moving or regulatory milestones we should be trying to hit in these 18 months? So, how, you know, and again, I think the questions are linked. You can try to answer them in a linked way if you like.
Well, I can take a first stab at it. You know, I think that we have a very good foundation for a reliance agreement that should be widely utilized, and we can simplify it, I'm sure, and make it better, but it's at least a foundation. You know, I think that the collaborative that we just heard about has a data use agreement. In the same vein, we should make that a national agreement. We have a BAA, and it, you know, those are the formulations in order to get to regulatory compliance. And I don't think that's so hard. The harder thing is taking, I mean, it's work, but it's not hard. The harder thing is educating the individual IRBs that are now pretty entrenched in how they think about their responsibility and their protection of the public. And educating that group of individuals, I think, is a challenge. And therefore, one of the things that, you know, Nancy Ruth and I have talked about occasionally is, are there ways of thinking about this so that it wouldn't, a certain set of activities would not be subject to IRB review, but rather a different governance structure? And I think that's possible.
Yeah, great question. So I'm just going to chime in a few random thoughts. One is, my own sense is that the public has no idea how much is left to be learned in clinical medicine. People know there isn't a cure for cancer, right? But in everyday medical care, I think people are shocked. And related to that, we also have, we are grateful that we have also a PCORI pilot grant, and we've been doing engagement sessions with patients, and we've been talking a little bit about the learning healthcare system and then what kinds of protections they'd like to have in place and how they're weighing things. And when we get to the part where we say, and one of the advantages is that everything that gets learned would be fed back and it would improve care, basically everybody's saying, that's not happening now? And there's sort of this shock and outrage. It's like, well, haven't you guys been doing research for a long time? Like, what's the deal? And that then ties to me, in my mind, into the privacy stuff, because something else that someone said, I'm responding now to some anecdotes, but in a different group with patient advocates, was this one person said, sort of people like me who have a lot of health problems keep saying, take my data, figure things out. And it is people who think that there's less to figure out who get particularly concerned about privacy. So anyway, it's an anecdote.
Thanks. That's a great end. And thank you to the panel and to Barbara for a wonderful session. So while we're transitioning speakers, people want to stand up and just, whatever you do when you stand up, enjoy yourselves for a minute, and we can get Paul and company up to the podium.